Endometriosis is a whole body disease affecting 1 in 10 females at birth. Despite being so common, the time to diagnosis often spans over 10 years and it is often thought of as a reproductive-only disease. In this podcast, we explore tips, tricks, and new methods to improve our day-to-day lives with endometriosis and adenomyosis. Hi, everyone. I am so excited to be here with Dr. Hadas Zisso today. Hadas is the founder and the brilliant mind behind EndoCure, a brand new endometriosis diagnosis and mapping tool. I hope I get the title correctly. I'm so honored to have you here and hear a little bit more about your journey, how you got here, and what does this new test do?
Thank you, Ruthie. I'm very excited for this opportunity to share more about what we're doing. Our mission that we are so passionate about is to bring endometriosis patients some kind of relief throughout their very difficult lives.
Preaching to the choir. I'm so happy you're here. What exactly is it doing?
Yes, it's actually an imaging tool that, if I want to simplify that, it takes the off-the-shelf ultrasound, as you know today, that is very, very manual and operator dependent, and transform it to a 3D objective imaging tool with very, very high resolution, automated imaging tool. And with that tool, we can actually detect very, very small 1 millimeter endometriosis lesions that are invisible today in any non-invasive imaging modality.
Wow, that is amazing. Yeah, we're going to dive a lot more into this in a second. But before that, let's talk a little bit about you. How did you get here? Like, is it a personal connection to endometriosis, or like what really sparked your initial interest in this?
Well, that's a good question. Sometimes founders have a personal story or someone from their family, but it wasn't in my case. And I'm quite a healthy woman, as we say. And I just felt for many, many years that I want to do something for us women. I didn't know how to do and what to do. I thought maybe I can volunteer somewhere, but I'm very dedicated to my career. I'm very busy. So I didn't get to it. And then, one day it clicked to me that I should do it through my career. And that's the best way to bring my, my capabilities, my passion just into the job. It's not, not just a job, it's much more than that, but to bring it into my career. And that's how I started. I just started to explore unmet needs in women's health. I'm sure you know there are many. But together with the gap, there's an opportunity. That's how I look at it. And I started to read about endometriosis. At the beginning, I just, caught my head and I didn't believe what I'm reading because, we are in 2025 and it seems like it was held back somewhere in the 70s. I don't know what's going on. I was very, very surprised to see how it's managed today and read deeper and deeper to understand it better. I talked with patients, I talked with physicians, realized true unmet needs, as you and the community are know better than me, from the late diagnosis, the poor diagnosis, the poor treatment options, no cure, no objective follow-up. All the disease management is like try and narrow vicious cycle throughout your lives. That's what I realized. And being a startup, I have to figure out also, it's not just philanthropy. I have to see if there's an actual business case here. And there definitely is, it's a huge market of 1 out of 10 women in reproductive age, 200 million women worldwide. And when I meet people, sometimes I have to educate them because they don't know about this condition. And I give them homework, go home and see, and you will learn that you know someone with this condition. And it's just like that. So it's everywhere, but invisible or transparent disease. And you didn't get this for nothing. So this is how I started and just, got deeper into my heart, especially talking to patients. If I'll repeat a story, I'll just start crying. Even if I tell you and you know this, and you know me by now, you can't stay indifferent to those stories, it's like you're going through hell throughout your life. And that's one of the reasons that I got more and more passionate about it.
That is incredible. We're so lucky as a community of patients to have someone like you, really, because really sometimes it feels, like you said, it's so lonely. It feels like we're the only one trying to fight for something here, for some sanity in our lives. And it's really touching. It warms my heart to have someone like you. I think that's why I don't even remember how we met like 2 years ago, maybe like a networking group or something. But that amazing spark in you really touched me. And I knew that whatever it is, how crazy and out of the world as it sounded, and you just went ahead and made it happen and got international recognition for it in multiple places, which is really, truly amazing. So, really, thank you so much. So, you said it's like a very specific imaging tool, but I know that like the go-to right now is MRI, which we all know is not great, but can you explain a little bit more about the differences between them?
Yes, of course. So the method in MRI and CT is quite similar, where the output is like a salami of the body. Okay, it's like slices of images perpendicular to one another that it has the information about the internal anatomy. Imagine just a piece of bread, okay, to make it simple. If you slice very, very thick slices, then you get very, very low resolution. You get everything uh, average inside this slice, yeah? And that's what happens in MRI. We are used to see MRI in the 2 dimensions. We see a perfect image, and that is true. In the 2 dimension, it's usually clear, no artifacts, not noisy image, fantastic. But we forget that it's actually very thick slices of bread over the body. So what happens is that if you want to catch, imagine in the piece of bread there's a small hole, 1 millimeter hole, and you want to catch it. You'll never see it with 5 millimeter slices, right? So it's the same for endometriosis lesions. When it's a large one, over 5 millimeter, of course, you'll slice this bread and you'll catch the very, very large hole in it. Okay, the same with MRI. If you have a large, deep infiltrating lesion, then absolutely you will see that. But if it's smaller than 5 millimeter, and 5 millimeter is like a bean, okay, it's not that small, but that's it. MRI cannot detect it. And that is the problem with the MRI. Now, with ultrasound, it's a little bit more complicated, because what we do, we use the same off-the-shelf machine, ultrasound machine, that a sonographer would use in the manual scan. So what's the difference, right? How come the robotic is successful in that and the manual scan fails? So there are a few reasons. One is that you need to be an expert in ultrasound. It's much more complicated than CT and MRI that are automated, and it almost doesn't matter who sits and presses the button, you will get the same result in every MRI you go to everywhere in the world. In ultrasound, even if you have the same machine, exactly the same model, different sonographers will get different results. Especially in endometriosis, it's a very, very challenging condition to diagnose, and you need to be an expert and see and be trained for years and years before you can say in confidence that you can detect endometriosis. So that's one element. The other one, even if now I invite the top one in the world, in the US, okay, and I will invite them to scan with an ultrasound, there's still the human factor, because in ultrasound, you have to interpret the data in real time. Again, unlike CT and MRI, where you get a disc, right, and you can sit with a cup of coffee, scroll through the data and think about what you see and compare multiple types of scan and think about it. It is usually the radiologist who is interpreting. Now, in the case of ultrasound, no, you have to interpret it in real time. So it's very difficult. No time for coffee, no time to relax, right? And the data goes in the screen goes too fast sometimes, because they have to go over the area of interest with introducer, go super slow, see what they interpret the data they see, and figure out what it is. So there's this limitation of the extent of data that our human brain can interpret in real time. So that's another element. And the third one is that the sonographer actually smears gel over the skin, right, for whoever experiencing that, and then pushes against the skin to have good contact for the ultrasound beam to be transferred. And then they just push in different angles, push the tissue around. So it's not a way of having absolute standardized data, if you know what I mean.
Kind of
And
like however they wing it, the same
yeah,
moment.
however the wing it depends. Each sonographer will approach in a little bit different angle and will get a different anatomical picture. So very much operator dependent. And the other thing is the velocity. The human hand cannot go, there's a limit to how slow it can go. Okay? You can do a test and try, just move your hand like that and you'll see, okay, I cannot go slower than that. You know, it's not possible. Of course, forget the fact that they want to save time and do it quickly, but let's say they have the patience and the time still, there's a limit. And the robotic system, of course, it doesn't complain. It can go as slow as you want. So another issue. Now, all of that together compared to what we are doing. Our robotic arm holds a transducer very, very stable and moves it over the area of interest while keeping the orientation of the transducer. This way we produce parallel slices like MRI. And we stream the data in a very, very high frame rate, 60 frames per second, to our software. So we get a frame, if you remember the salami of the MRI, we get a frame every 100 micron. It's 10 times higher than MRI.
Wow.
So we have a very, very high resolution, and this way we can detect the very small 1 millimeter lesion. All together with that, the final output will have AI-based software that will flag the lesions, and therefore every technician can operate the system with no knowledge whatsoever of endometriosis, just know how to adjust and select the protocol in the ultrasound machine, and that's it. It produces repeatable, reproducible, objective imaging with a very, very high resolution in 3D.
Wow. That is so futuristic. It sounds like, something not, wow, what a time to be alive. And this just works with the regular ultrasound, just whatever they have in office?
Almost, yes. Of course, it has to be better to have quite a good machine and not the very low cost. There are some parameters that are important, like imaging depth and so on. But in general, yes, it can be any company, any machine that exists today. Yeah.
Wow. That is that. Where do I sign up? Oh, actually, one second before I sign up.
At the end, yeah.
Does it
But
hurt?
you said future, so actually, yes, the future is now. We have a system, a fully functional system ready for first in human clinical studies that we're about to begin here. So all is set and ready. And we're excited to go into this stage. Yeah.
Okay. I'm gonna follow up with you, and we might have another chat like this in like a few months when you share with us what you what you found, because I can't wait to hear the actual the results. I know it's gonna be astonishing and groundbreaking, but I just can't wait to hear it from you. But hold on, going back to my question, because I'm like just thinking about a robot, and it's not even a person. Like, does it hurt? Like, how much pressure is there? Is it internal, external? How does that work?
Yeah. So it's a transabdominal approach, and one of our thoughts was in our design was to minimize the pressure that is exerted on the skin. We have a special mechanism.
This is a pain thing, We're trying to diagnose something that is very painful. Let's not hurt more. Again, thank you for this. Really.
I know it's an issue for you and sometimes, or always being ignored, especially when you have to do the transvaginal test, and you know these are important. So they
Terrible.
say you don't have a choice just to suffer during the test. So yes, we hope to we'll know as we discussed in the clinical studies, but we assume that we will be able to see even deep into the tissue, 20 centimeters deep into the tissue with a transabdominal approach, while just moving the transducer row by row over the area of interest. And we have this mechanism that keeps the contact with the skin. You must have that for the ultrasound beam to be transferred, but with minimal pressure. So that's one of the unique things that we do.
That is amazing. And from the way you describe it, it sounds like the default is to scan the entire stomach. So we also like check a larger area than would be checked normally. Is that correct?
Yes, absolutely. So I know that the common practice varies, with different physicians. Every expert has his own methodology, and that's okay. And we heard out of our market validation with them that most of them are doing only the vaginal approach with, of course, a very good 3D imaging transducer, but still the vaginal approach is limited because it has the extent, that it can go, I don't know, 10, maybe if it's a very good transducer, 15 centimeters deep into the tissue. So they definitely cannot see the kidneys in this approach. And I'm sure some of you have experienced lesions on the ureters of the kidneys blockage and stuff like this. So on one hand, it's not so common. The statistics shows that most of them are in the lower pelvic area. But I do know that some experts do both vaginal and abdominal approach exactly for that reason, to locate other lesions. There could be lesions on the intestine, and if you look only vaginally, you will definitely miss them. So we can scan exactly like you said, the entire area from the lower pelvic up to the ribs, have all data with, with the
Wow.
same setup, minimal effect on time duration of the scan, and just have it all for the physician to interpret it. Yes.
Wow. That is huge, I have to say, because right now I feel like it's so much reliant on how good the patient is at explaining the symptoms and like how good the physician is at interpreting, oh, this might be more than just pelvic. Maybe it's like more because we all I think every endometriosis patient have stomach issues, and sometimes, we don't know to detect how severe is it. Like, do I actually need to get tested? And I have to fight for an MRI that is like gonna take 2 hours now because I have to do the entire area. So, yeah, this is a huge thing that's coming up. What's the future for this? So this is like going into testing, and then how does that work? Like, when do I get to go to my doctor and ask for it?
Yeah. So as for the pathway, we expect to have 120 patients in our first in-human clinical study here in Israel. This will be followed by a larger joint US-Israeli study. And this will also be our data for FDA submission. In parallel, we are pursuing FDA clearance. As you know, this is a must for medical devices. We expect to have the first clearance within about a year now,
Okay,
Jane. Yeah.
coming up.
Yeah, and the clinical studies will probably be available in the US even sooner than that.
That's good.
Yeah, and initially, I'll be happy also to describe, as I see it at least, maybe you'll have more ideas of the use cases of our tool, because it's not only the initial very important complete diagnosis that you mentioned, it doesn't end in that. It can be used as a tool for surgery pre-planned, that today is either blind or very partial information based on MRI. As we talked before, this shows only the larger lesions. It can be used as a tool to adjust the drug levels. Even if it's hormonal drugs, it's not just like that. It's not so simple. It's a trial and error process. And we can shorten that or even eliminate that by providing objective follow-up. And not less important, actually be a tool for continuous monitoring. As you know, it's a progressive chronic condition. And if the physicians will be able to catch it and intervene on time, then you could have much better quality of life, maybe even prevent the infertility problems, prevent the pain from becoming casual to chronic and constant, and all those effects that are very, very important if you can intervene on time. So the intervene is not only at the initial identification, but throughout your life with this chronic condition. And I think that even in the future, my hope is that there will be new emerging drugs for cure of endometriosis. And I think that also there will be an importance to monitor the effect of the drugs, to adjust the right dosage per patient, because each one reacts differently. It's such a
Right.
complicated condition that was not even investigated fully as to its etiology, because I think one of the reasons is that it was invisible to date. So
Yeah.
that's one aspect of the imaging, let's call it imaging diagnostic part of the use cases. And the other part is we think it can even be used for minimal invasive procedures. For example, today they do interventional radiology procedures under city guidance, like RF
Right.
ablation, cryoablation, all of those. And these could be good solutions for endometriosis if you can tell, exactly where you should aim and target it with ultrasound instead of CT, and have the real-time imaging monitoring the needle
Right. As it goes
entrance
in.
into the tissue. Then it could be a fantastic minimal invasive approach, much better than laparoscopy that you have to go today. So we think that it can also affect the therapeutic approach, and I have also future dreams for non-invasive therapies, but that's for the next chapter.
I love where your brain is going with this. Please continue to think about endometriosis all day long. You are amazing. Wow, this is impressive. I feel like this could potentially also be a tool for when to not intervene. I think I heard one of the specialists describe it like some endometriosis looks like black pepper or poppy seeds, like tiny, tiny, tiny little things that intervention not necessarily is going to make it better. It might actually make it worse. And there is no way for us to know that. For me as a patient, I have no way to make an informed decision on this. Like, is it going to get better? Is there a chance of it getting worse? And I feel like if we have such accurate kind of like imaging and we will know, okay, yes, I go in, this place is kind of like problematic. This might hurt more. Maybe let's not do something about it. And I love the potential future of having a discussion about it instead of like going as a patient. I felt like I'm going blind. I had to like completely trust that person, which she was amazing. Like I'm really grateful she saved my life, but it was really scary. And I feel like it would just help me. And I feel like just even sometimes not doing anything, but having the answer and knowing, oh, that is why is such a big thing for me as a patient that alone is worth it. Even if it's not going to help me cure it, which I'm going to ask you in a second about that, it's still going to
Yeah, yeah,
be
yeah,
very
yeah.
huge.
Yeah, I think you have a really good point here where it can be a decision supporting tool. I know, like they do in prostate cancer, they call it active surveillance. You keep monitoring, you don't have to intervene if it's unnecessary, right? Like you said, because the surgery has side effects, it can cause adhesions that can worsen the situation for you as you already have ones. It can cause pain, and who knows if this pain disappears or not. There's a 50% chance of recurrence post-surgery, according to the studies. You're absolutely correct. This can be a decision supporting tool both for the patient and the physician,
Yeah.
together or separately, but it can be a tool, yeah, to decide. I mean, if they have, when our solution will be accurate and flag all small lesions, they can say, okay, if there's nothing here, probably doesn't worth to operate, like you said. And if there's something small, okay, maybe you just want to monitor and see if it gets larger or not, and then decide according to that. Today,
Yeah.
you're totally correct. It's just blind decisions, symptomatic-based decisions that you're just taking a bet on your health.
Yeah. And the symptoms like are so confusing, right? Because another use case that I jumps right to mind is like so often I see, patients having surgery and then 2, 3 months after that, terrible flare up, going crazy, and like, oh my God, everything is back, everything is back, which is a totally normal reaction to have because I feel the pain exactly where it was, exactly how it was. Like everything is back. If I could go in and have a relatively cheap test, like an ultrasound, that just tells me yes or no. Do you need to freak out? Do you have that type of endometriosis that comes back right away? Yes, there is one very aggressive or two very aggressive types like this. Yes, but it's not everybody. But flare-ups are very common, or like the need for pelvic floor therapy is so common. And sometimes, like, if I go to pelvic floor therapy, but I actually have lesions there, it might sometimes make things worse or just not help at all. Or I think I'm going into surgery and I have met someone who went into 3 surgeries before she realized she actually just needed pelvic floor therapy because she just kept having the same problems and the same pain. And something
Okay.
like this could be just so helpful to know what's going on. Actually, it's
Yeah.
huge.
Yeah, so it's not just for the surgery, but for the entire complementary treatment that goes together with that, and maybe even for, how do you say, when you go with the small needles, and sometimes it helps to elevate the
Oh,
pain.
acupuncture? Ooh, yes. I feel like that would be very, like, yeah, you don't want to ever hit something that stay. That
Yeah,
would be
so
so
they also
painful.
have, yeah, they also need to know where to aim. So it could be helpful there, and maybe even for exercises, anything. If you know where it is, you can
Yeah.
react accordingly.
Yeah. I'm not a pelvic floor therapist, but I've been to pelvic floor therapy for like 8+ months. So I consider myself a bit of an expert. And I feel
Yeah.
like at least my pelvic floor therapist, she's super knowledgeable, she would love to have imaging like this to better understand me and better tailor my treatment. So I feel like that would be a huge thing for them too. I know we're getting towards the end. I have a question. Why is it called EndoCure? I know that right now it's more imaging than a cure.
Yeah, yeah. Well, I said that when I started, I had dreams of bringing also a cure with non-invasive ultrasound therapy. But in a startup, you cannot have it all in one day. You have to take it step by step. And we figure out that it's worth to concentrate on the imaging part first and build that. And like I said, we can have a working product in the market super fast. So that's very important because when you do therapeutics, it's quite a long journey with the clinical studies and the regulatory and many other aspects, the safety, of course, all of that. So it's a much longer journey, and maybe someday we'll get there too. I hope so. And that is why I started with the EndoCure, but it gives hope for the future.
It does. It does. We believe in you as a community. I personally strongly believe in you, and it would be so interesting to see what you come up with because really, like when I talked to you 2 years ago, I was like, she has a brilliant mind and an amazing dream, but you actually made it reality. So this is truly inspiring. What advice would you give to someone who suspects they have endometriosis right now?
Oh, wow. First, trust yourself. Don't listen to anyone who's telling you it's just in your head. Simply not. I heard a story of a patient recently who had to hurt herself because she was not sure she knows what pain is. Yes, terrible, just terrible, terrible things. And just never doubt yourself. I'm sure you are strong, wonderful women, and don't let anyone question how you feel. That's the first one. And I do believe in the strength of the community, and I think it's great, Ruthie, what you've built because you can consult one another. And I know it can be very helpful both practically and mentally to be supported by others and to support others. As for us, yeah, I really do hope that we'll reach the market as soon as possible and can bring some kind of relief. As I said, not only for new diagnostics, but for all of you that it will allow to monitor, or like you said about yourself, Ruthie, maybe even to make it better for you when you will know where the lesions are, what's going on inside, maybe you would change some of the things that you are doing today daily. It can have a huge effect on the way of life and of course on the treatment options.
Ben.
So
We are going to have a lot more information about this and a way for you guys to sign up to hear first about it when it gets to your state. So stay tuned and get on the Yellow Hub. And obviously, we will have links to EndoCure and to learn more about Hadas and her future journey. I can't wait to have you back here and hear more about where this is going. Thank you so much for this. Any last words for us?
yes, actually, I will be presenting EndoCure in the International Congress in Miami next month. So whoever is interested, of course, it's a very deep into medical issues Congress, but maybe some of you will find that one very interesting.
Thank you so much for this.
Thank you.